Very good evening to all of you. I hope all the students are having a good time and you guys are running the marathon at the right pace that should be. Okay, so my job is every week. I will show up every week in order to discuss questions with you, which have been possible questions that have been asked in your previous NEET-PG as well as INI-CET. Now it has come. Previously, we used to have only NEET as well as we used to have AIMS and PGI separately. But all in all, it all happens to be under the same frame. Okay, so the basic idea of these word rounds is your participation. And I want to discuss these cases with you. Why? Because in order to generate that kind of thinking of a clinician. So plainly, just reading basic sciences will not fetch you the answers when you enter inside clinics. But the basic or the most important thing. Yeah, there is some disturbance that is coming. Hello. Nice. I think somebody is, I think somebody's microphone is on. Yeah, I think it's better now. Yeah. So the basic idea of these word rounds is to basically generate that kind of a clinical concept inside you, and so that you can even enjoy these kind of basic science reading. Okay. So my funda is very simple. Whatever you read, put it into clinics, your concept becomes double stronger. Okay. So now today, what I will do, I will change it a little bit. In the last or the previous word round, I was very vocal about, I was teaching, I was telling you a lot of things, but I want you to participate into it. That is what will make it a lot more fun. Okay. So I want you guys to come in, you guys to tell me, and you guys to teach me what you read in the last week. Right? Okay. So I'm going to go question by question, just as my own patients. These are my patients that have been constructed, and I'm going to take you and I'm going to fetch answers from you as to what do you think has happened to this particular patient. Okay, fine. So now I want the chat boxes to be open. And in the chat boxes, I want active participation of the students. And to keep answering, even if you are answered it wrong, I won't mind. I want wrong answers so that I can fetch the right answer out. Okay, I want every student to answer in the chat box, and I want each and every student to be crystal clear before they exit out of this word round. Right? Fine. So let's start our word rounds with question number 1, our first scenario of today. Right. So now the first scenario is a 55-year-old man has complaints of burning in his abdomen. Okay, there is a kind of a burning sensation this guy has been telling, and it is associated with pain, and it appears after when he starts eating. Okay, these are the important points. When he starts eating, he's having that symptom. While eating, it subsides, and sometimes it recurs after 2 hours of eating. So while eating, it goes off, then again it comes back. The patient is a chronic smoker and has a higher intake of caffeine. In an endoscopic examination that was conducted in the hospital, small ulcers were found in the antral region of the stomach. So inside the stomach, in the antrum, we found certain small ulcers. The following is the cause of development of gastric ulcer in a chronic smoker. Now, what is the cause that you think this particular ulcer has happened in this chronic smoker who has been taking a lot of caffeine too? Is it because of hypersecretion of gastric acid, or because of the disruption of the protective layer that is present inside the stomach, or less bicarbonate concentration in the mucosal layer, or is it because of production of ammonia? Come on. Now, this is a very, very important scenario because these are the type of patients you will see in your everyday life. Ulcers in the abdomen. Now, in this particular patient, when you found the ulcer, you have come to the diagnosis that this ulcer has happened. What do you think in your mind is the reason for that ulcer to form in such a lifestyle? Out of these 4 options. Okay, so Satrupa has answered B, that is disruption of protected layer. Umang says it is because of less bicarbonate concentration in the mucosal layer. Anyone who has anything else? Okay, Anjali thinks it is either A or C, or she has got another option into it, hypersecretion of gastric acid. So there is a lot of confusion. We have got all 3, except for production of ammonia. Everybody has answered. Ram Pranav Sai says A. Okay, so whoever answers, I'll stop there. Okay, so I think Ram Pranav Sai has got the right answer. Partially, Anjali also got it right, but A or C, she was confused. Now, can we have Ram Pranav over? Yes, Anisha, it is A. Right. So the answer is A. Now, any one of you, can come over and unmute. I would call Ram Pranav to be off on the mic. Can you come over on the mic, please? It's a very, very basic thing. Don't worry. I'll just answer what made you think that it is A. It is the right answer. But what made you think? Ram is there? Are you guys able to unmute? You can write over on the chat box if you are not able to unmute. Anisha, are you there? Can any one of you tell me what exactly made you think why it is hypersecretion of gastric acid? Because the coming questions will generate the same kind of a concept. So I want to make it clear here itself. Any one of you? You're not able to unmute? Anyone? You can write it over on the chat box if you're not able to unmute. Okay, no one? You don't want to attempt it? You are my junior consultant. See, these are my rounds. You are my junior consultants. I would rather wait and want that thing to come out from you. See, why I said hypersecretion of gastric acid. Exactly. Right, Anisha. Caffeine as well as nicotine causes hypersecretion of acid. They are stimuli. So they will go and they will cause the parietal cells of the stomach to secrete more and more acid. And because of the acidic secretions are more, this particular person develops a gastric ulcer with time. And because of that development of an ulcer, he produces these kind of symptoms. So you just need to see two important points here. One, that it is a gastric ulcer. Two, that it is because of an agent that has been mentioned also. He's a smoker. He is consuming a lot of caffeine, which causes hypersecretion of this. Now, why not B and C? Why not B and C? Let's talk about it. Because disruption of the protective layer and less carbonate concentration causes more duodenal ulcers. Okay, I am talking about a gastric ulcer. See, there are two types of ulcers which happen. Gastric ulcers, duodenal ulcers. Okay, in the duodenum, they are duodenal ulcers. Now, gastric ulcers, in the classical sign of gastric ulcers are, whenever a person will eat food, the pain inside the stomach will subside. And whenever that food empties out, again, the pain will come back. That is a classical example of gastric ulcers. Here, the classical example is also being given. So one, it is stimulated by some agents, right? And it is not because of disruption of protected layer and carbonate concentration, because they are more prone for duodenal ulcers, right? Protective layer is also maintained by the prostaglandin concentration, correct, right? As well as production of ammonia. Why is production of ammonia not important here? Because production of ammonia is mostly related in H. pylori infections. Whenever there is an H. pylori infection, which is the most common cause of our particular ulcerations, ammonia usually tends to play a role in that, right? It is increased in that. It increases the gastric acid production in those cases which have H. pylori as the causative agent, not the other two, not caffeine and not our smoking. Okay, so now you understood why I called it gastric acid, why not the other three examples. This is what exactly you need to generate and why it happened. Everyone is clear for the first round, right? Anyone has any kind of problems in this particular questions? Okay, fine. So I can have a thumbs up and you guys can keep answering over on the chat box. And this is the thing that I'm going to go ahead with, right? Okay. Now I come to the second question. So this is a question that was asked in NEAT-PG. Okay, this is the same question. All your questions are from NEAT-PG and before. Now, in the following case that you have already read, okay, in the above case, same scenario, the patient gets aggravated or exaggerated pain as the patient started taking an NSAID, okay, and he also had a toothache. So for the toothache, he took an NSAID. NSAID are non-steroidal anti-inflammatory drugs, which you find like diclofenac, ibuprofen. These are all NSAIDs. Now, the following is the cause of exaggeration and pain in this particular patient. Because of NSAID, what happened? Hypersecretion of gastric acid happened. Because of that, he had pain, or disruption of the protective layer happened, or bicarbonate concentration in the mucosal layer was more, or was it because of ammonia? Now, what happened? Only Anisha has answered. I want everybody to answer. There are so many students over online. I want everyone, okay, to have got two answers of B. Anyone thinks any other answer except for B? Except for B, anything else? Okay, now let me come back to your a little bit. I'll get back to your basic understanding of your pathology as well as your physiology. Okay, have you guys understood arachidonic acid pathway? Have you heard about arachidonic acid pathway anywhere? Anywhere have you heard about arachidonic acid pathway? There is something called as an arachidonic acid pathway. If you have heard, then you can write it over on the chat box, because this is what I'm going to generate inside you. Hemostasis, no, not hemostasis, Anisha. Arachidonic acid pathway, if you have not heard, you will read. It's a very important pathway that is going to come in your pathology as well as physiology as well. Arachidonic acid pathway is the pathway by which our body generates something called as prostaglandins. Okay, prostaglandins are very important to us. There are various types of prostaglandins. Now, those prostaglandins are produced by a pathway called as arachidonic acid pathway. Now, prostaglandins are, one of the functions of prostaglandins is to protect our digestive lining. So there is a very high quantity of prostaglandins in our digestive tract, which protects that lining from getting disrupted. Okay, now what happens when we take NSAIDs in a very high concentration? These are called as non-steroidal anti-inflammatory drugs. Why anti-inflammatory? Because they are prostaglandin inhibitors. So what they do, they inhibit that pathway. So less prostaglandins will be there, so more disruption of our protective layer mechanisms will be there. And that is the reason they will cause more exaggerated pain in such patients. Now you understood. So if a patient has come with gastric acid ulcers, or if he has gastritis, will you give any kind of diclofenac or you will give Brufen for any kind of pain relief? Absolute no, because that is going to exaggerate his symptoms more. You understanding now? So these are the small tricks and things that you need to think now as a clinician. I never regard first year people as non-clinical. Okay, you are more clinical than us, because you are in touch of those things which even I have forgotten. I don't remember the whole of anatomy, whole of physiology. I just remember the clinical aspects of it. Okay, so you are more than me right now. So you should enjoy, right? So now understood why NSAIDs can cause this particular issue, or how the disruption of protective layer happened, right? Can I move ahead now? Right. Okay. So now I think things are clear. So I'll move ahead. Everyone is clear. I'll move ahead to the third question of my word round, and that is coming up here. Come on, guys. These are the easy questions. I will really pump up with multiple questions with you in the times to come. Okay. Now I move to question number 3. 62 years old female has the complaints of heartburn and stomachache. Heartburn is acidity in simple terms, and stomach issues, stomach pain. Now the endoscopic examination shows inflammation and patchy gastric ulcers. See, I'm still in the ulcers because now it has got to do with H. pylori. Helicobacter pylori is a particular microorganism which causes gastric ulcers. Now, H. pylori is the commonest cause of developing gastric ulcers, and it increases by the following content in the gastric mucosa. What is that content? Now, see, I've already given you that hint before, if you are hearing me. What is that basic mechanism of developing a peptic ulcer in Helicobacter pylori infection? What is that? I've got Anjali saying C, Anisha saying B. Anyone else has? Yes. Satrupa has told B. Okay. I told you this answer. Yes, Ram Pranav has told B. Anjali, I think you got confused. C, gastrin. C. That is what? Simply think about H. pylori. Put ammonia with it. H. pylori, always put ammonia with H. pylori. Okay. Whenever I'm talking about H. pylori as the agent, ammonia is the causative agent. Now, why does ammonia happen to have? What is the problem with this ammonia if it increases in our gastric secretions, or if it increases in our body in the gastric mucosa? Anyone? What happens with this ammonia? What happens? So ammonia is increased by which enzyme activity? Okay, accumulates in the liver. I would say liver disorders produce hyperammonemia. Okay, that is one of the reasons. But what exactly is happening here? See, when urease enzyme activity increases, ammonia increases. What will ammonia do? As soon as ammonia will get increased because of this H. pylori specifically, it will lead to disruption of our protective layers. It will straight away percolate in our gastric lining and it will destroy it. Once our lining is destroyed, what is that destruction in the lining called as? It is called as an ulcer. See, what is the definition of an ulcer? Ulcer is a discontinuation in the lining of any particular area. If this is my lining and this has got disrupted like this, we call this particular thing as an ulcer. Simple. So what is ammonia doing? Ammonia is basically a toxic product that is formed because of urease activity, which is increased by Helicobacter pylori. And because of the hypersecretion of ammonia, it causes a disruption in the lining of our stomach. And because of that lining in the stomach is disrupted, that protective mechanism is there no more, and it finally leads to an ulcer formation. Simple. Now, indirectly, that ulcer, once it will get formed, it will lead to more H plus ion concentration. Finally, it will lead to more gastrin, more chloride, but it is not directly connected. It is all indirect. But the direct communication is with ammonia. Understood? So simple terms, whenever you get an ulcer question, you put ammonia with H. pylori, you will get your answer. Simple. Got the answer? Okay, clear? So I'll move ahead. If you guys are clear, I'll move ahead to my fourth question, right? I've got thumbs up, so I'll move on to my fourth scenario, or fourth question coming for you today, and that is here. Right. Now, 54 years old male was admitted to the emergency department after having a syncopal episode and hematemesis. Now, first, let me make things clear here. What is syncopal? What is syncope? Anyone? What is syncope? Because these are the things that you need to understand first before reading any question. Anyone for syncopal attack? What do you mean by that? You can use a lay term or also layman term also. I don't ask for definitions. Definitions destroy things. Just tell me. Even if you tell me in Hindi, I will understand. Anything. What is syncope or a syncopal episode? You can write it down on the chat box. Sudden blackout. Okay, more or less you are right. These are kind of fainting-like episodes. Okay, dizzy episodes. So suddenly the patient will feel very dizzy and they will say, okay, I'm going to fall down. Okay, these are called as syncopes. Okay, and what is hematemesis? Vomiting of blood. Correct. So hematemesis is vomiting of blood. Now, so this particular person came with sudden blackening episodes, as Anisha said, sudden attacks of faintiness, as well as vomiting of blood. And on an emergency basis, they did an upper GI endoscopy. It shows multiple ulcers. Now the ulcers were in the duodenum. Now the serum gastrin levels were 8 times higher than the normal level. So you know that gastrin is something which causes secretion of acid more, right? It's a hormone which it secretes more of your acid that is in the stomach. More gastrin, more acid that is there. Now, the following is the diseased condition suspected in this case. That means his serum gastrin levels were sky high. And because of that, he developed ulcers. And because of the ulcers, he had hematemesis. Now, what do you think is gone wrong in this patient? Okay, Ram Pranav has already answers. Great. Anyone? No, I think. Wait 1 second. I just missed out on the chat. Yes, Anisha and Ram Pranav has answered. Zollinger-Ellison syndrome. Anyone else who wants to answer? Come on. I have only 4 or 5 students who are answering. I want all the students to participate. Even if you're telling me wrong, it doesn't matter. Because here you are wrong, I can correct you. Yes, Satrupa has also answered it A. Anyone who wants to answer anything else except for that. Anyone. Because that is the area or the loophole. Okay. Now I would like to tell the people who have answered A to put me the answers why you think it's Zollinger-Ellison syndrome. Why you think this particular thing is Zollinger-Ellison. It's very, very simple. See, these scenarios are there to confuse you, and this is what NEET is bent for. NEET confuses you. Okay, they will give you such big scenarios. You'll see, oh Baba, this is such a big question. How will I answer it? They are all very simple questions with very logical answers. Now think what I have told. Okay, anyone who wants to tell me why they think it's Zollinger-Ellison. First, you tell me what do you mean by Zollinger-Ellison? This is a syndrome that I understand, but what happens in this? No mugging up. Anyone? You can write it over in the chat box also. Anyone wants to go for any attempt of Zollinger-Ellison? Achalasia GERD are not belong to duodenal ulcers. Okay, so he is going the retrograde way. Okay, that is also a correct way of answering. See, so Ram knows about achalasia and he knows about GERD. And he says that it's not related to the duodenum anymore because things are not going up till the duodenum. They are only at the level of esophagus and stomach. So that's a good way. So he knows that achalasia GERD cannot be there. Because increased secretion of gastrin secretion due to tumor in G cells of the stomach. Absolutely the right answer, Anisha. That is the right way. Okay, so Ram and Anisha both are right. So why it is Zollinger-Ellison syndrome? Zollinger-Ellison syndrome is a particular syndrome that is usually presents with gastrinomas. Okay, what do you mean by gastrinoma? Now see this term. Gastrin means it is the hormone. Oma means a tumor, right? Oma, wherever you put, it's a tumor. We call it adenoma, lipoma, or carcinoma. What is oma? Oma means a tumor. Okay, so gastrin secreting tumors are a characteristic of Zollinger-Ellison syndrome. So in these particular patients, you will have very high gastrin levels because they are gastrin secreting tumors that happen. And because these gastrin secreting tumors are present, these people are very prone to producing very high levels of gastrin and very high levels of acid. And because of that acid, they produce very high amounts of ulcers. And because of those ulcers, the ulcers can likely bleed. And because of these bleeding, they can come in the emergency and they can suddenly, why the syncope happened? Because of the sudden vomiting of blood, he lost a lot of blood. And because of the sudden drop in blood, he was hypotensive. And because of hypotension, he suddenly collapsed, right? That is why the 54-year-old male presented to you. Okay, so always remember, achalasia is a condition which is related to the esophagus, where the esophagus is not able to open up. It is a constriction at the lower end of the esophagus. That's called as achalasia cardia. Hirschsprung disease is something which is congenital. It is a colonic motility disorder. Okay, it's a congenital colonic motility disorder, usually happens in the sigmoid colon, right? And GERD or GERD is basically something which won't present to you with ulcers in the duodenum and sudden bleeding like this. Okay, they will produce with heartburn. Okay, a sudden stuffiness over in my chest. That is what these things will be for GERDs. But yes, if the only thing that is present here will be there, so Zollinger-Ellison will become the right answer because of gastrinomas. Everybody clear? Right? Clear, everybody? So now I believe everybody is understanding these cases. If you're not understanding, then I'll stop there itself and I won't move. This is the whole idea of my word rounds. I need each and every student to get clear and then start enjoying what you're reading. Okay, fine. So now we are clear. Fourth question is done. Now we move on to the fifth question. Now, in the above case, what you just read, the following is the most likely to be another sign associated with this disease. So that is why, see, this is how, again, now if you don't know Zollinger-Ellison, it doesn't matter. I told you some things about Zollinger-Ellison syndrome. Now, what will be the associated sign with this? Now, see, this is how Shifa has come up with D. Great. Anyone else wants to tell me what is the other sign that you can think, or what is the classical symptom that you will see in such patients of Zollinger-Ellison syndrome? Anything? Anyone? So, okay, I'll go one by one. Why not A? Hypotrophy of gastric mucosa. Acha, okay, Anisha has answered A. Why do you think it's A? Arun also has answered A. Why do you think it's A? Hypotrophy of gastric mucosa. See, you know, gastric mucosa lining is getting stimulated again and again because there is so much of acid inside. Okay? So much of acid is getting secreted because of gastrinomas which are present. This gastrinoma is secreting a lot of acid that is again and again stimulating your gastric mucosa. What happens in our body if there is stimulus given again and again? What happens in our body? As a stimulus, as a protective mechanism, body will start layering up cells over it, or the cells will become larger. What do we call that? We call that hypertrophy. If a normal cell becomes a big double in size, we call it hypertrophy. If they increase in the number, we call it hyperplasia. Simple. So hypotrophy cannot occur. There will be always hypertrophy. Why? Because there is so much of gastric acid which is again and again stimulating my stomach. So obviously there will be not hypotrophy. My gastric mucosa is very smart. It will try to protect it. So it will increase the size of those cells which are present in it. So there will be hypertrophy of the gastric mucosa instead of hypotrophy. Okay, that could not be there. Difficulty in swallowing cannot be an option because this is not a problem with esophagus. Difficulty in speech cannot happen because this is not a problem with my oral cavity or my tongue. The only thing that can happen here is steatorrhea. Absolutely right. When I got the first answer, Shifa, it was right. Why steatorrhea? Now stimulate your physiology. Pancreatic lipase comes in what part? It is released in what part of the intestine? Pancreatic lipase. Which part of the intestine does my pancreatic duct open? At the ampulla of Vater, as simple as that. My pancreas, yes, duodenum, absolutely right, Shefa. So my duodenum is the area where my pancreatic duct is opening. Now, because my pancreatic duct is opening there in the duodenum, if you have something in the duodenum like an ulcer, what will happen? My pancreatic lipase activity, when it is coming out in Zollinger-Ellison, there is also pancreatic involvement. Okay, Zollinger-Ellison is got multi-system disorders. It is not associated with just gastric ulcers. It has got pancreatic insufficiency also in it. So what happens? Pancreatic lipase activity comes down. What is the problem with pancreatic lipase? Pancreatic lipase is a cutter of fat. When no fat in cutting will happen, they will lead to fatty stools. And what is fatty stool called as? It is called as steatorrhea. Understood? Now you guys are understanding how exactly the symptoms are working. Okay, so I'm not teaching you Zollinger-Ellison syndrome here. I am teaching you your physiology, whatever you have read, pancreatic lipase and this and that and digestive enzymes, where you can put in these questions. You are going to read this Zollinger-Ellison syndrome in surgery in later time. Okay, you're going to get this syndrome multiple times because this is your long answer question. But the thinking process should start from now itself. That is what the main idea of this water round is. That you know something like Zollinger-Ellison exists. Now you guys will be very well versed that yes, we know something about Zollinger-Ellison. See, when I was first year student, I'll tell you my story. I never understood what is all this. Okay, Zollinger-Ellison, though I never even heard about it till I reached final year to read surgery. Okay, so that is why you should start reading clinics from here itself. Okay, understood? Fine. So now I'll move on to the next question. Everybody clear on this one? Right. So I've got a thumbs up. Right. So I'll move on to my second or my next case. That is my sixth case of today. So these are big cases, but the whole idea is to keep you engaged. Okay. Now see, these are the scenarios where your teacher will tell you, okay, read and tell me what is the diagnosis. Chalo, now tell me. 35 years old man was admitted to the emergency department. So this is something which is an emergency, and with complaints of nausea, vomiting, and severe epigastric pain. Now see, you guys are also reading quadrants of the abdomen. Okay, now think epigastric pain this person has. Okay, so what all things you can find in the epigastric area? Stimulate your minds. I'll come back to you. Okay, now the pain was aroused after binge alcohol drinking. So there was a stimulus, he binged out on alcohol and he developed this kind of a pain. On examination, there was fever, there was overall weakness, there was pallor, there was cold, clammy skin, which was observed. So what does this indicate? Fever, weakness, pallor, cold, clammy skin. What do you mean by this? That this patient is hypotensive. Hypotensive means what? That the blood is not circulating enough in every part of the body. That's why he's pale, right? He's anemic, as well as he has cold, clammy skin. So whenever there is less blood pressure or there is hypotension, all our extremities become cold. Okay, so this patient has come in hypotension also, and that's why you see the blood pressure is quite low, 95 by 70. That's why you have this cold, clammy skin. Okay, now we go for, in order to confirm what it is, we go for a CT scan, and on the basis of palpation and the CT, it shows that his pancreas are enlarged. Now you must have noticed when you were taking quadrants of the abdomen, you have got pancreas. Okay, now which quadrant pancreas is solely in? Tell me that quadrant. Where do you find pancreas? Which quadrant of the abdomen do you find pancreas? Think. Which quadrant of the in your abdomen? There are 9 quadrants. Which quadrant will you find pancreas? Simple things. Come on, write it down. This is very, very simple. Okay, this is nothing got to do with my question is more dangerous after that. Okay, so anyone, which quadrant do you find pancreas? Solely. Chalo, anyone? I hope you guys know that my pancreas are somewhere here. Okay, where is my pancreas? I've even shown you. Epigastric left, upper left quadrant is, yes, I can tell that. But now you are doctors. Come on, you have to tell me exact names of these things. Epigastric, there is an extension of that. Yes, hypochondriac. Yes, absolutely right. So you tell these things, right? Chondrium, left hypochondrium, and a part of it extends to the epigastrium also. So Anjali, absolutely right, epigastrium and left hypochondrium. Gopika is right, left hypochondriac. So all these regions have pancreas. Okay, epigastric, small part of the epigastric and left hypochondrium. has the major of pancreas. Now, what has happened in this patient? In this particular patient, after having a lot of alcohol and drinking, he had pancreatic swelling or pancreatic enlargement. We call this particular condition as pancreatitis. Okay, that we generally have a lot of pancreatitis. We call it acute pancreatitis or chronic pancreatitis. But after a binge alcohol drinking, usually they lead to acute pancreatic enlargements or acute pancreatitis. Itis means inflammation. So pancreatic inflammation is acute pancreatitis. Okay, so this patient has acute pancreatitis. That is my first thing. Now, the following is the most likely to be true in his laboratory test. What can be true here? What can be true? So Ram Pranav has told B. So what can be true in this particular case? Any person. So this is acute pancreatitis that I've already helped you out. Come on. Anyone? Okay. Okay. Anjali says A. Ram Pranav says B. Now, any one of you who wants to go for COD? Shifa also wants to say A. Okay. Anyone for constipation or anyone for leukopenia? Okay. Now I'll first come back and correct. High serum alkaline phosphatase levels is the right answer. So whoever has answered it A, absolutely right. Why? Whenever there is pancreatic enlargement or whenever there is pancreatitis, okay, it is associated with the release of a lot of enzymes into the circulation. One such enzyme that is released in the blood circulation is called as alkaline phosphatase. And that activity increases. That is why when you read acute pancreatitis in surgery in your final year, you will get to know there is a criteria for this. Okay, this criteria exists, which is a question in your papers. So I'm not going to tell you the criteria and go into acute pancreatitis, but just remember that whenever there are pancreatic enlargements, the whole enzyme activity is released or increased. And when these enzymes are increased, they lead to high serum values. So one such enzyme that is increased is alkaline phosphatase. Now, why it cannot be B? Blood urea nitrogen levels are decreased. See, I already told you the patient is hypotensive. Now, when the patient will be hypotensive, will there be blood reaching the kidneys? That will be less. If the kidney is getting less blood, will the blood urea get flushed out easily? Absolutely no. It will start accumulating in the body. So it will increase in the blood urea because my kidneys are also not getting enough blood so that they can flush out the extra urea that is present inside. Absolutely. Right. So decreased blood urea cannot be there. It should be increased blood urea. Right. Now I come to the other two. Okay. The patient is already having fever and the patient is already come with a pancreatic enlargement. These people are more prone to inflammation-induced leukocytosis. See, whenever there is enlargement, inflammation, or anything like that, there will be more of my cells which build up inside in order to fight my infection, right? So there cannot be leukopenia. There will be leukocytosis, means increase amount of these particular things like my white blood cells, right? And why it cannot be constipation? Now again, tell me pancreas and all those things. Why there cannot be constipation here? There will be what will be the stools be like? What will be there if pancreas are affected? How will the stools be? Come on, I just now told you about that when I was telling you about Zollinger Ellison ka kahani. So how will the stools be here? They cannot be constipated stools. Come on, any one of you. How will the stools? Steatorrhea, absolutely, Anisha. There will be steatorrhea. Why pancreatic lipase activity is not happening? Your fat is not getting cut down. It will lead to more fat buildup and it will lead to stools which are very fatty. Correct? Clear? So now you understood how to counter this particular questions. How these big questions are just to scare you. But they actually are very, very simple to see. As soon as you enter and by the time you exit this study-a-thon, right? After 90 days, I am going to make sure that you start answering such questions rapidly. Okay, that your thinking goes into that. It's got a lot of lateral thinking. You are in a field where your brains are built up for thinking. Doctors are great thinkers. So always remember that your lateral thinking should always work. It is not about I read physiology, no, only physiology, no. Physiology, anatomy, biochemistry, pathology, everything is connected. Okay, fine. So now I'll move on to the next case scenario if everybody is clean on this. Okay, I'm going to take some time over these scenarios. I'm not going to take time over on one-liners, which are in biochemistry. I'm not going to take time on them. I'm just going to take some time on these scenarios because I want to stimulate that thinking. Okay, now I move on to the 7th question. Okay, again back to something. Now read this properly. 65-year-old female rheumatoid arthritis patient had been on NSAIDs or non-steroidal anti-inflammatory drugs. We have already known that there are some diclofenac, ibuprofen. All of these drugs are NSAIDs. And disease-modified drugs, which are given basically for rheumatoid arthritis, we call them DMARDs. So they are given for rheumatoid patients. For almost 10 years, this patient has been taking these drugs. In the last 6 months, she started noticing generalized weakness, loss of weight, and loss of appetite. So she has weight loss, weakness, and appetite loss. So I'll tell you a story, okay? In India, half of the things that happen in clinics is wrongly diagnosed or misdiagnosed. Why? Because people don't think or they don't evaluate them. Everybody, if the patient is having, I'm feeling weakness, they will give some multivitamin and tell the patient to go. You are not going to be that kind of a doctor. You know that there are 10,000 things that can cause this particular condition. So this is something which is very general. Everyone has, I'm feeling generalized weakness, loss of weight, loss of appetite. Critical. These symptoms are very, very critical and red flag signs. And now you see what happened to this patient. On examination, pallor of the skin was observed. That means this patient was anemic because there was pallor. Pallor means anemia. Okay, paleness or pallor. Now, blood analysis was done. And in our blood analysis, we have a parameter called as packed cell volume. Okay, there is something called as hemoglobin. We have packed cell volume. Now, anytime, whenever you are at home, you go and search your parents or your grandfathers or your grandparents' blood reports. Okay, take that blood report and read those parameters. What are written on them? It's a very good habit. Okay, so you'll find this PCV written on it. What is packed cell volume? Okay, and this packed cell volume was quite less, 25%. That indicates that this patient is anemic. Okay, now what would be the type of anemia in this patient? Is it normocytic, normochromic, microcytic, hypochromic, macrocytic, hypochromic, macrocytic, normochromic? All these are stories, but they are all very simple answers. Shiva is fast enough to answer microcytic, hypochromic. Anyone else for any other thing? See, I'll tell you how this thing is going to go from where to where. Okay, this is how things are stimulated. Come on, anyone? Okay, now let me stimulate you. Okay, which type of anemia are you thinking? Forget about normocytic, normochromic, microcytic, hypochromic. Forget about all these terminologies. These are all pathological terms. What type of anemia are you thinking here? There are various types of anemia. What types of anemia do you think can happen here? There is something called as iron deficiency anemia. There is something called as megaloblastic anemia. There is something called as pernicious anemia. What do you think is, okay, Gopika thinks it's pernicious. Umang says it's ideal. Okay, now again go back to listening what the patient is telling you. Okay, again now I'm going to tell you another story. Okay, this patient is having NSAIDs. Okay, this patient is having rheumatoid drugs for 10 years. Because of this rheumatoid drugs and NSAIDs, this particular drug leads to what? It leads to gastritis. You know that. I've already discussed with you that it leads to gastritis. Why? Because it causes an inflammation of the gastric lining or inflammation of the gastric mucosa. Now, because of the inflammation of the gastric mucosa, what is this particular drug doing? Because of the constant inflammation, it goes and it atrophies the parietal cells. That means the parietal cells that are present in my gastric mucosa, they are going to get destroyed because of constant NSAID intake. Correct? Because of constant NSAIDs, all my parietal cells are going to get destroyed. Now, because of the lack of parietal cells, it will lead to less acid secretion. Because of less acid secretion, they also produce something called as intrinsic factor. So no parietal cells means less acid, less intrinsic factor. Intrinsic factor is required for the absorption of which vitamin? Which vitamin is required for absorption of, which intrinsic factor is required? Yes, Anjali, it's B12. So if B12 will be less, it will lead to which anemia? Which anemia will it be? Megaloblastic anemia, not pernicious. Megaloblastic anemia. Okay, I'll tell you, pernicious is going to come. When pernicious will come, I'll tell you the story of pernicious. but it will lead to megaloblastic anemia. Vitamin B12 deficiency will be because of megaloblastic anemia. Okay, so when there will be megaloblastic anemia, it will lead to which kind of a picture on pathology? What kind of things are here? Now I'll tell you a trick how to tell it is megaloblastic. Okay, it's normocytic, normochromic. No, not normocytic, normochromic. So it is macrocytic normochromic. Okay, remember this. So when there is megaloblastic anemia, there is macrocytic. So I used to remember this way: macromegalo. Wherever macro comes, it is always megalo. Okay, macrocytic anemia always is associated with megaloblastic conditions. So macrocytic normochromic anemia is the right answer in this. Answer is D. So you understood the logic behind. It's not about this pathology. Did you understand the whole logic? Logic was NSAIDs were taken by a patient. NSAIDs went inside, destroyed my parietal cells. Because it destroyed my parietal cells, there was less intrinsic factor, less acid. Vitamin B12 was not absorbed because of lack of intrinsic factor. It led to megaloblastic anemia, and that is the reason. Now, if I put her on a vitamin B12 dosage, high dose injections, I put her on this, she will be fine. Absolutely fine. Understood? Right? So now I'll move on ahead. You understood the story. See, this macrocytic, normochromic and all, I'm not going inside in depth because this will come in your pathology. They will make you understand what it looks like on slides, how you differ it out. It will come. But I've kept this question for you just to make you understand how this whole vitamin absorption complex comes inside in these complex questions and how you have to get your thinking right. Okay, enjoyed? So if you have enjoyed, please give me something over on the chat box that you are enjoying, and I will move ahead with my next question. Okay, so this is what the reward rounds are. Simple. Okay, now I come to the next question. That is the 8th question. That a 33-year-old male follows a very healthy dietary habit, but after 20 minutes of finishing the meal, he has a strong urge to defecate. Now he has this problem. As soon as he eats, he feels defecating out. Though in 20 minutes the food remains in the stomach, the reason of the occurrence of defecation reflex is, see, the stomach emptying time is not 20 minutes. It takes a little longer, but he still has that urge to defecate. So what is that reflex called as? Is it called as enterogastric reflex or gastrocolic reflex or intestino-intestinal reflex or rectosphincteric reflex? See, I'm still telling you, still the food is in the stomach. So what will be the reflex? Again, I told you, still the food is inside the stomach. So what is the reflex? Gastrocolic reflex. Simple. See, this question can be attempted even if you don't know any of these reflexes. Just think, if there is something inside the stomach, see, I've written also, though in 20 minutes the food remains in the stomach, so it cannot be anything. It cannot reach the rectum. It cannot reach my intestines. It cannot, entero means again the intestines. So these reflexes have been named after where exactly they occur. If I'm saying enterogastric, that means this reflex is happening between my intestines and gastric. Gastrocolic means colon starts stimulation and it starts, contracting and relaxing faster, which is induced by the gastric area. Intestinal means it is happening solely in the intestines, and rectosphincteric means when the food has distended the rectum. So it causes sphincter relaxation. That is called as rectosphincteric reflex. So the answer is gastrocolic reflex. Simple. Got the answer? Right? Simple. So I'll move on now to my next question. Anyone has any doubts on this? I'll move on to next. Right? Everyone is clear? Answer is B, gastrocolic reflex. Okay, fine. Now I move on to the next question, 9th question, and here it comes in front of you. 62-year-old female was investigated for the complaints of abdominal pain and vomiting. With the help of ultrasound and CT findings, the malignant organic lesions were found in the iliac region. Now see, this is only to make you confused. All these malignant organic lesion, all this is confusion. So what they did for that malignancy, they did a surgical removal of the iliac region. Iliac means basically the intestinal region, okay, ileum. They have done an ileal resection. Now, what will happen to this patient? Now finally Anisha has got it right. So what will happen in this patient? Come on, megacolon achalasia, atrophic gastritis or pernicious anemia? Everyone clean? Yes, now finally. So because of the ileal resection, now the person will develop pernicious anemia. because obviously they cannot absorb anything. And what is absorbed in the ileum? Which thing is absorbed? Yes, vitamin B12 will not absorb, as well as absorption of folate. Folate will come down, and that will lead to pernicious anemia. Atrophic gastritis cannot happen because you are resecting out an ileum here. So obviously it is out of logic. Achalasia happens to be inside my esophagus. So it is not at all related to any ileal resection. And megacolon is also something which is because of it is in this, the particular intestinal segment becomes 3 to 4 times than the normal. Okay, it becomes distended. That is why we call it megacolon. Okay, so it happens because of lack of neurons which are in the myelinic plexus, they lose, and that is why it becomes distended. Okay, so all of these three things cannot happen. The only thing that can happen is pernicious anemia. Now, when you read this question, it becomes very difficult to understand. You feel very scared when you read it. But by the same time, see how simple things are. If you just know your basic physiology, just see ileum, just see pernicious, finished. It has to be pernicious. Okay, fine. So now I'll move on to my next question. So this is clear, everyone, whoever is there, everyone, all students clear? Chalo. I'll move on to the next question now. Fast, so that your dinner time, before your dinner I finish. Okay. Now I come to the 10th question. So this question, it seems to be such a hi-fi question. 54-year-old male patient was brought to the casualty with complaints of upper abdominal pain and hematemesis. Okay, again upper abdominal pain. So the endoscopic examination showed duodenal ulcers. Okay, now the biopsy appeared to be negative for any H. pylori. So they were just ulcers, no H. pylori. Blood sample was having multiple times higher basal gastrin levels. Okay, now gastrin is very high. To detect the presence of gastrinoma, which of the following substance can be used as a confirmatory test? Now you tell me, what happens as a negative to gastrin? If gastrin is high, which hormone will be increased to negate it? If gastrin increases my acid, what decreases my acid? Which hormone is opposite to gastrin? That is your answer here. Which hormone is opposite to gastrin? If gastrin's secretion increases gastric acid secretion, there is one hormone which is mentioned here which decreases gastric acid secretion. Which hormone is that? The answer is that. Cholecystokinin. Everybody is for cholecystokinin. Again, think. Cholecystokinin. Yes. It is secretin. Absolutely right. Right. Secretin is a hormone that is always ulta to gastrin. Gastrin will always increase gastric acid production. Secretin will decrease gastric acid production. So why we call it a secretin confirmatory test is because if you give secretin to this patient, usually what should happen? It should decrease the gastrin, right? But in gastrinomas, when they will be there, even if you give secretin from outside, gastrin secretion will not stop because these gastrin secreting tumors will keep on secreting it. So that is a confirmatory test that we call a secretin confirmatory test. So what will it indicate? That this patient has gastrinomas. That means even if I'm giving secretin to this patient, it is not able to counter the activity and still my gastrin is getting secreted and secreted and secreted and it is causing duodenal ulcers. Now you understood the logic behind it. CCK or cholecystokinin, pentagastrin and GLP, these are all hormones which are related to very less activity on gastrin. Whenever you get gastrin, secretin, put it in your brain, they are all opposite to each other. Okay, so the answer is A. Understood? Clear? Okay, can I move ahead with my next question? Are you guys getting it, what I'm trying to tell you, or how we are doing these word rounds? The simple logic is that. Okay, you need to get in that. So are you guys enjoying it? Because you guys need to enjoy all these things. I don't want to keep a copy and pen, just keep writing it. Okay, you guys need to enjoy MBBS as much as you can. Right. So now we have got 10 questions ready. Now I move on to the 11th question. Now I'm into somewhat anatomy, and that is the favorite segment for everyone. Okay. Now, 40-year-old male with a history of lumbar tuberculosis. Now I'll tell you very simple terms because this question has been asked to you multiple times in multiple exams. So always remember this type of question. Whenever it will come, there will be very, very simple logics behind it. This patient has lumbar tuberculosis. Okay. Now, TB, lumbar tuberculosis means TB not only affects our lungs, it also affects are bones. Okay, this is the vertebral area which I'm talking about. So lumbar TB is basically the lumbar segment of the vertebra that has been affected, and they come to the OPD with chief complaints of fever, back pain, and limp. On examination, there was a swelling in the inguinal region that was noticed. Now, CT was performed and they noticed that there is a low density mass that was seen in the retroperitoneum. Now, first, let me ask you guys, retroperitoneum, what is the boundary of retroperitoneum? What are the boundaries of retroperitoneum? It is I hope you guys know it is something that is behind my peritoneum. That is why it is called as retro, means behind the peritoneum. There is a space called as retroperitoneum. So this is a very vague space, right? And it is just in front is my posterior part of my parietal peritoneum, and behind are my muscles. This is a space which is called as retroperitoneum. And if you guys go and recap your retroperitoneum, it has got 3 important spaces. Can you tell me what are the spaces of retroperitoneum? Come on, guys. This is your recall. I need to see how much you guys are reading. Anyone? Have you heard about perirenal space, anterior pararenal space, posterior pararenal space? These are the spaces of retroperitoneum, right? So in this particular space, there are certain things inside, right? There are certain organs in your retroperitoneum. Now, if a person is having TB, this person has TB, what can happen here? Can it cause inguinal lymph node enlargement? Can it cause kidney disease? Can it cause psoas abscess? Can it cause inguinal hernia? So I've got only one answer from Ram Pranav, that is psoas abscess. Now think. What exactly is there in the retroperitoneum? What space in the retroperitoneum, or the space in the retroperitoneum, what will it cause? Which muscle is there in the retroperitoneum? Now you tell me. Only 2 muscles are there in the retroperitoneum. What muscles are there? One is psoas major, and another muscle is quadratus lumborum. These are the most major muscles that are present in the retroperitoneum that are bordering it, right? So if there is any kind of lumbar TB always leads to abscess formation. You just remember this, okay? You might find cervical TB. You might find a cold abscess here in the neck, okay? You might find any space in the body wherever these abscesses are growing. TB is one of the causes which causes it, okay? If a person has lumbar TB, definitely this can also cause an abscess. And that abscess will be called as what? It will be called as a psoas abscess, because psoas major muscle is present in the retroperitoneal area. And that area is the one which is guarded by this muscle, and it produces an abscess over it, which is called as psoas abscess. Now, why it cannot be inguinal lymph node? Because it is not in that area of retroperitoneum. Frankly, kidney happens to be in the retroperitoneum, but kidney disease is a very vague thing. Lumbar TB cannot cause a kidney disease straight away like that. Okay, because this patient is also limping. Now see, limp. Why did the limp come? Because my psoas major is getting contracted again and again. That's why that patient is limping. He's not able to walk. Inguinal hernia cannot be a right answer because it is in the inguinal region. So the only thing left is psoas abscess. Understood? Anyone has any problems in understanding this question? Very, very simple question. Understand it. See, and another point why this is an abscess is fever. Fever will always be with abscesses. See, all things are towards this. Okay, you cannot find a kidney disease with fever, just like that. Okay, so that is how you tend to figure out answers. Even if you don't know them, even if you know 2 things in this, you can figure this thing out as psoas abscess. Understood? Are you guys clear? Can I move ahead? Okay, so these are the simple things that you need to master upon. Okay, don't feel hurt, don't feel bad. These are just the starting what I'm giving you. Very, very simple questions. Okay, now I come to my favorite. 45-year-old male, victim of several stab knife injuries, and that knife injuries happen to be over in the abdomen. And they subsequently developed a direct inguinal hernia. Now, this person has a direct inguinal hernia. Hernia means what? Hernia means protrusion of our normal contents. So when normal viscera or my contents of my body, they start protruding out through natural orifices, that particular thing is called as herniation or hernia. That means some part of thing has come out as a protrusion or a hernia after he developed a stab. Now, damage of which of the following nerves is most likely for predisposing weakness of the anterior abdominal wall? Now, what do you think is the right answer? Okay, Gopika has tried as C, subcoast. No, what have you answered? You have answered ilioinguinal. Okay. Ilioinguinal, everyone for ilioinguinal. Okay, anyone for any other answer? Anyone for any other answer? What do you think? Ram Pranav also is confidently saying, everybody is saying confidently ilioinguinal nerve. Okay. Now let me tell you, ilioinguinal nerve is absolutely the right answer. Okay. Now why am I saying ilioinguinal nerve? See, subcostal is always next to my coastal ribs. It cannot be because there is a stab wound abdomen. It cannot be subcostal. Now I come to all of these branches. First, let me discuss about ilioinguinal nerve. Now, can any one of you tell me the course of ilioinguinal nerve? Where does this ilioinguinal nerve come out? See, my funda of anatomy is to always go to the parent and come back to where it is. Okay, ilioinguinal is the content of the inguinal canal. Absolutely right. But where is that coming from? Partial, yes, absolutely right. But where did the story start from? Where did it start? Kahan se aaya hai? Where this ilioinguinal term came? See, it has got two branch of the lumbar plexus. Absolutely right. If I say ventral ramus of L1, okay, so absolutely right, Anjali. Ventral ramus of L1, okay, superficial inguinal ring, it's a little far from the ventral ramus of L1. That is my lumbar plexus. This particular ilioinguinal nerve comes out. Now see the term here, ilioinguinal. It has to be somewhere in the iliac region and somewhere in the inguinal region. That is why this term is ilioinguinal. Okay. Now, once it comes out, it is always situated in my retroperitoneum. Okay, in my retroperitoneal area. This particular nerve is posterior to my psoas major muscle. Okay. Once it is coming down behind the psoas major, it comes down and it comes to the iliac fossa. Now, in the iliac fossa, your iliac fossa is like this, right? It's like a scoop. Over that, there is an iliacus muscle. Because it comes over the iliacus, that is why it comes with the name of ilio. Okay, now iliacus has been crossed now. So again, I'll repeat, lumbar plexus. From lumbar plexus, it is posterior to the psoas major. Then it comes down over the iliacus muscle. Once it comes down to the iliacus muscle, it pierces the transversus abdominis. And because once it pierces our transversus abdominis, now it comes into the inguinal canal. And now once it comes into the inguinal canal, it is always superficial to our spermatic cord, because spermatic cord is also one of the contents of our, if you remember, in your inguinal canal in males, right? So it is above your spermatic cords, and then finally it goes on to the inguinal ring, and then it descends down. So now you understand how that course happened. Lumbar plexus, psoas major, iliacus, transversus abdominis pierces out, comes into the inguinal canal. Inguinal canal, it is superficial to the spermatic cord, and then it goes to the inguinal ring. This is why the name is derived with ilioinguinal. Now, simple. If it is ilioinguinal and if it is coming into my into my inguinal canal, if there is an injury of this particular nerve, it will lead to a direct inguinal hernia. Simple. Right? Understood? Anyone has got any doubt in this? Have you guys followed me where I went? Okay, so it's all about imagination. You should ask yourself 2 times why this femur, why this particular nerve is ilioinguinal, why this nerve is genitofemoral, why this nerve is pelvic splanchnic. See, all these terms are beautifully being designed in anatomy. They tell you where they come from and they tell you where they go. So when you will become great surgeons ahead, when you become great physicians ahead, you will cross these nerves every time in your life, and then you will say, this is a nerve that I know the whole course. That is what strong makes you. Okay, so don't go behind these question and answers and mugging them up. Always make very, very plain, simple concepts, which can get you a long way. Okay, fine. Now I move on to my next question. Okay, now 20-year-old man develops a rectus sheath hematoma. So this has already been taught to you before. Rectus sheath has a hematoma because there was a blow to the abdomen from the anterior side, and it led to a rupture between an anastomosis of superior and inferior epigastric arteries. So there is some superior epigastric artery, there is inferior epigastric artery, and it ruptured the anastomosis. Which blood vessel is the source artery for inferior epigastric artery? Chalo, now let me see. Inferior epigastric artery is a branch of what? Okay, now again I'm giving you a hint. This particular artery has got 3 branches. Internal iliac, external iliac. Okay, Anisha says external iliac, Anjali says internal iliac. Anybody else wants to say anything else? Anyone? Anyone? Anything else? Okay, so the thing is, external iliac artery is the right answer, and it has got 3 major branches. Your external iliac has got 3 major branches. What are the branches of external iliac? You have to tell with me now. Okay, I'll tell you this 3 arteries. Remember these 3 arteries. External iliac artery has got 3 branches. Okay, first branch is inferior epigastric artery, which I've already told you here. Inferior epigastric artery is the first branch. Second branch is femoral artery, and the third branch is deep circumflex iliac artery. So what are the 3 branches? Deep circumflex iliac artery, femoral artery, as well as inferior epigastric artery. These are the branches of our external iliac artery. So the answer becomes external iliac artery. Got the idea? Right? So these 3 branches, now you guys will remember these 3 branches. What are the branches of external iliac artery? Remember these 3 arteries which I have told you today. What are the 3 arteries? Again, inferior epigastric artery, deep circumflex iliac artery, and femoral artery are branches of external iliac artery. Now, these 3 branches are going to come a lot in your questions. That is why I'm again and again telling you. They're going to again and again come. Okay? So always remember this 3 branches. Whatever comes other than that, it's all internal iliac. Okay? Chalo. Now I'll move on to my 14th question for you. Okay. Now, a patient reports to the emergency with severe back pain following a road traffic accident. He also complains of loss of sensation in the left side of his groin. Now, important, read this question. Left side of his groin, he has loss of sensation. Now, on examining physician notices that there is no elevation of testis on when medial side of the upper thigh is lightly stroked. Okay, so this is called as a cremastic reflex. Okay, so what exactly you do in this particular reflex, that when you stroke the medial side of the upper end of the thigh, there is elevation of the scrotum and the testis. That is called as a cremastic reflex. Now, name the nerve that innervates the muscle responsible for reflex elevation of testis when eliciting the cremasteric reflex. So what is exactly, basically, they want to ask you in this whole question, which is the nerve which is responsible for cremasteric reflex? Okay, anyone? Okay, already I've got answers. Yes, C is the right answer. It is the genital branch of the genitofemoral nerve. That is absolutely right. Now, can anyone tell me that what exactly is this genital branch of genitofemoral nerve? What exactly is this cremasteric reflex all about? Can anyone tell me this cremasteric reflex? So this cremasteric reflex is a reflex which happens to be because once we stroke or lightly stroke the upper end of the medial side of the thigh, okay, there is some kind of a nerve stimulation. Now, because of this nerve stimulation, some nerves carry this impulse and some nerves get this impulse. So basically for this reflex, you have got an afferent limb and you have got an efferent limb. That means some nerves take this reflex, some nerves bring this reflex. Okay, so what exactly has happened? Once we stroke, yes, it is because of the cremaster muscle. Once we stroke the medial end of the upper end of the thigh, some nerves that are present there take that signal and go to the brain. And what is that signal taken by? This signal is taken by femoral branch of genitofemoral nerve as well as ilioinguinal nerve. So these are the afferent branches. Okay, remember that. So these branches take that signal. And once they come back, afferent branch, yes, afferent is the femoral branch of genitofemoral nerve. Efferent means that now the brain knows, now there will be an elevation of the testes as well as the scrotum, and that is brought about by the genital branch of the genitofemoral. So don't confuse in this question. The afferent branch or the branch that is carrying that impulse to the brain is the femoral branch of genitofemoral nerve. And the branch that is causing that reflex or the efferent is the genital branch of genitofemoral nerve. I am asking about that this thing didn't happen. That means I'm asking about the efferent branch. So that is why the answer becomes genital branch of genitofemoral nerve. Understood? Okay, clear? Yes, Anisha has already written. So this is the thing that I'm already telling. She has already written there. So you guys can just check it out. She has already written the afferent and the efferent branch. So it is a femoral, which is afferent. Efferent is genital. Remember that. Okay, I'm promising you, if you just follow these questions, right? At least not all, but at least 2 or 3 questions in your papers you will strike. I'm definitely telling you. You will at least get 2-3 questions from this, from all of this related. Okay, so always think in all of these questions. Understood? So can I go ahead? You guys have understood this question? Into my next question. Okay, fine. So I've got a thumbs up. I'll go on to my next question. I don't want your energies to be down. I want your energies to be pumped up, because doctors never have low energies. They're all pumped up people. Okay, fine. So 23-year-old male patient, 23-year-old patient is admitted with suspected appendicitis. Now, first tell me, which quadrant of the abdomen is this where appendix is present? This is my quadrant of the abdomen where my appendix is. Which is this quadrant of the abdomen where my dot is? Chalo, fatafat you tell me in the chat box. Which quadrant is this? Yes. So this is my fine. Anjali, one more attempt. Anyone? Right. It's the right iliac segment, right? So don't confuse. This is the lumbar segment. This is the iliac segment, right? So this is my right iliac segment where my appendix is, right? No need to say sorry. This is how khatakat you can build yourself up. So now you won't forget, because my teachers used to always, tell me that if you tell something wrong, you will definitely never forget this for life. Now, this appendix has enlarged, so that is called as appendicitis. That means now appendix is enlarged. Now the patient states he's having pain around the umbilicus. So basically what happens is when our appendix is enlarged, it causes a pain around the periumbilical area too. It causes pain even here in the lower part of the abdomen. So this patient has appendicitis. Now in addition, he says that this pain is the worst on the lower quadrant, and patient points to his abdomen at a location which is about 1/3 distance between the anterior superior iliac spine and the umbilicus. So if we draw a line here, this particular point is the area where he points. What is this point called as? Very, very important for surgery point of view. I've already got a right answers. Yes, this is the right answer. So all of you remember, C is the right answer, McBurney's point. Why? Because McBurney was a New Yorkshire surgeon. He was the first one. His name was McBurney, and he was the one, Charles McBurney, who was the first one who actually did a lot of work over on appendix. So that is how McBurney became McBurney's point, and that is basically a point which indicates appendicitis. The patient says, I have exactly pain in this area, and this point is present at a distance. If we draw an imaginary line, it lies 1/3 between the distance of the umbilicus and the anterior superior iliac spine. It happens to be in between there somewhere. So this one number point is called as McBurney's point. Okay, remember, appendix means McBurney's. That is why we give an incision also here. That is called as McBurney's incision. As simple as that. So McBurney is all about appendix. Okay, so remember McBurney's point. So this is simple things. Okay, we'll move on to the next question. Everybody clean on this? Everybody is done? Okay, McBurney's point. Any particular questions that you guys have at any particular point, please stop me. Okay, fine. Now we move on to the next question. 16. A 62-year-old man complained of swelling in the groin. Now read this. Superomedial to pubic tubercle, which became prominent on coughing. That means there is some kind of hernia. But what hernia is this? If there is any swelling in the groin superomedial to the pubic tubercle, what hernia is this? Come on, tell me. That means some kind of protrusion is there. When he coughs, some swelling comes out. Is it femoral hernia? Is it inguinal hernia? Is it Litter's hernia? Is it enlarged lymph node? Okay. Anaga is saying femoral. Karnamay is saying inguinal. Then Anisha is also saying inguinal. No, femoral. Okay. Again, I'm telling you, this is superomedial to the pubic tubercle. Think. Pubic tubercle is in almost the center of your hip. Okay. It is supero and medial to it. Will you find femoral area there? Femoral area will be next to the thigh. Correct? So if you have any kind of a swelling in and around the medial end of the thigh, usually it will become femoral. Correct? But if you have any swelling in next to that area where you have mentioned, so you will always get this question. Groin, superomedial to pubic tubercle. Groin, superomedial to pubic tubercle. Always think inguinal hernia. Nothing else. Okay. Litter's hernia is not something. Litter's hernia, Anjali, is basically a protrusion of the Meckel's diverticulum. It is a condition in children where this is called as Meckel's diverticulum when it protrudes out of the abdominal wall. Okay. That's called as Litter's hernia. That's something related to the Meckel's diverticulum or the intestines. Enlarged inguinal lymph node cannot be there because this swelling is coming out on coughing. So it has to be a hernia. Lymph nodes will stay all the time. So inguinal hernia is the right answer. Whenever you see a medial end inner thigh swelling, always go for femoral hernia. But here, whenever you see groin, superior-medial to pubic tubercle, it is always and always inguinal. Got the idea? No confusions. Okay. So these are the clinical vignettes or clinical points that you need to take home. Okay, fine. Should I go ahead with my next set of question? Okay. So now I'll move on to my 17th question, and that is integrity of the inguinal canal is maintained by various mechanisms. So you know my inguinal canal has a very strong influence of certain muscles. So contraction of my external oblique muscle approximates the two crura that are present, which is the medial and the lateral crura that are present over my inguinal canal of the superficial inguinal ring. And this particular mechanism of contraction is called as what? What is this mechanism in which my superficial inguinal ring is closing and opening again because of the contractions made by my external oblique muscle? How is it keeping my ring intact? What is that mechanism called as? Anyone? Is it called as flap valve mechanism, shutter mechanism, slit valve mechanism, ball valve mechanism? What is the mechanism here? So this particular mechanism, I'll just correct Anjali here. This particular mechanism is slit valve mechanism, not shutter. Remember this mechanism. Your superficial inguinal ring is just like a ring like this. This inguinal ring is basically it because of the contraction of your external oblique. This is your medial crura. This is your lateral crura. When the external oblique will contract, it will close this off. Right? This particular, now see, this my hand looks like a slit. It is closing and opening. This looks like a slit. That is why it is called as slit valve mechanism. Simple as that. Okay, so the contraction of my external oblique muscle approximates two crura, median and lateral, of my superficial inguinal ring by slit valve mechanism. Understood? Okay, this is something even if you don't know, you can add on to your theory. Okay, if you have not read or if you don't know this, then add on to your theory. It will be an extra knowledge to you that I've given it to you today. Okay, fine. No, I'll definitely explain. I'll definitely come back because I have got some amount of questions left so that all of you don't doze off. I'll definitely explain it to you once I finish this segment. Okay, I'll come back and I'll explain it because I have got some questions left and I've already exceeded the time and I'm going very slow. So that is why I want to finish this and then I'll come back. Okay, Anjali, I'll definitely explain you all the other mechanisms because they are not related to this. There are other mechanisms in other things. Okay, that is why I have to tell examples to you. It will take a lot of time, so that's why I've come back. Okay, now a 65-year-old manual laborer noticed a gradual swelling that was present, and this swelling was painless in the right groin again, increased on coughing or straining in toilet. Now, physical examination again revealed, see, again it came. Swelling in the superior-medial to pubic tubercle. Now, first thing is, this is inguinal hernia that you already know. Now, the most probable diagnosis and how most probable diagnosis of the defect is in. So basically, which type of defect they are looking for. Is this a femoral hernia where superficial inguinal ring is defected? Is this a direct inguinal hernia where superficial inguinal ring is affected? Is this indirect inguinal hernia where deep inguinal ring is affected? Or is this indirect inguinal hernia where superficial inguinal ring is affected? All sorts of confusion. Okay, so this is a confusing question to you. But here I will tell you one trick. Ram Pranav has already told it is femoral hernia to superficial inguinal ring. Okay. Now let me make certain things clear. Okay, there is a test. Okay, there is a test we do for hernias. Okay, that test is called as three-finger test. Three-finger test is called as, now see this 3 looks like a Z. Okay, so Z, say you can remember Z-man test, Z-E-I-M-A-N-S. So Z-man's test is a test, also we call it three-finger test. Three-finger test means we keep our 3 fingers over the 3 openings that are present likely to cause herniations. And what are those 3 areas? One of our finger, we keep it over the deep inguinal ring. One finger we keep over the superficial inguinal ring. And one finger we keep over the saphenous opening for the femoral hernias. Okay. Now, then we tell the patient to cough. Whichever finger pulsates, we get the answer which type of hernia is there. Now, how do we do this kind of a test? Okay, we have got 3 fingers, right? Now, the index finger is kept over the deep inguinal ring. the middle finger is kept over the superficial inguinal ring, and the ring finger is kept over at the saphenous opening, that is at the medial end of the thigh. Okay, so deep inguinal ring, superficial inguinal ring, and saphenous opening. Now, if I get an impulse at my deep inguinal ring, it is indirect inguinal hernia. If I get an impulse over directly my superficial inguinal ring, it is direct inguinal hernia. And if I get an impulse over my saphenous end, that is femoral hernia. This particular test is called as a three-finger test, also called as a Z-man test. Now, this particular patient has come to you, okay? And you see there is a swelling in the groin. Now, always remember, two types of hernia are there. Indirect inguinal hernia, direct inguinal hernia. Indirect inguinal hernia always take the longer route. That is, they come from the deep inguinal ring, then they come to the superficial inguinal ring, and then they come into the scrotum. Okay, but the direct inguinal hernias are called direct because they don't come via the deep ring, they directly come into the superficial ring via the posterior wall. They break through the posterior wall and they directly enter into the superficial ring. Now see this. This particular man is a 65-year-old male. Okay, that is my first clue that this is an old age problem. In old age, my abdominal wall viscera or my abdominal wall musculature is weak. Now, once he coughs or strains, he develops a groin swelling, which is superomedial to the pubic tubercle. So as soon as you see superomedial to the pubic tubercle, the first thing that comes in your mind, it is not femoral. I already told you, it cannot be femoral. So it can be either it is direct or it is indirect. Correct? Now, what exactly I told you? That this man has got a superomedial swelling to the pubic tubercle. So when I do a Z-man's test or a three-finger test, it will be at the superficial ring, which is just above the pubic tubercle, and direct inguinal hernia will become the right answer. See, because I'm already telling you it is above the pubic tubercle. So the deep ring is not there above the pubic tubercle. It is a superficial ring there. So what impulse will I get there because of a direct inguinal hernia? Had it been from the deep inguinal ring, I would have called it indirect inguinal hernia. Are you getting? It's confusing. It's difficult to explain you hernias here because it's a very, very huge topic. But again, now you understand the right answer would become what? Again, the right answer would become what? It's direct inguinal hernia, which is at superficial inguinal ring, or B, as Karnamay has actually told. Right. That is the right answer. So don't worry, even if you didn't get that concept, I will get back to you over when hernias, you will get back hernias, because hernias is a huge topic. You will learn these kind of tests, but this is just to generate that thing. Okay, I'll tell you another important clue. Whenever you are getting 65-year-olds and all, right, always think direct hernias, because they are all related to abdominal wall weakness. Whenever you are having lower age group around younger males, it is always indirect. Okay, so always remember, direct hernias usually occur in the later part of the age group, but indirect hernias usually occur in the earlier part, in the younger age group. That is another clue here. Got it? Fine. Now I'll move on to my 19th question. Okay, now I'll be going a little fast so that you guys won't drop out and you guys are not exhausted enough, because it's almost your dinner time. So I'll just quickly finish off your 25 questions for today, and just 6 questions are remaining. Okay, a 55-year-old man with history of chronic smoking and cough noticed a gradual increasing swelling in the left groin. Okay, now physician manually reduced the hernia and he confirmed that it was direct inguinal hernia. Which is the combination which is true for a three-finger test or Z-man? See, Z-man test has already come. So I've already told you what is the Z-man's test. Okay, what is Z-man? Can everyone tell me? Index, middle, and ring. Index finger we use to palpate what? Index finger for deep inguinal ring. Middle finger for superficial inguinal ring, and ring finger for saphenous opening. So deep, superficial, femoral, right? So if suppose I put these 3 fingers, so see this, if I put the index finger at the deep inguinal ring, I will get an indirect hernia. Simple, right? Do I use a middle finger at the deep inguinal ring? No. Did I use a ring finger at superficial inguinal ring? No. Did I use an index finger at saphenous opening? No. Only this is right. Simple. So index finger for deep ring, middle finger for superficial ring, and your third finger for saphenous opening. This is what the Z-man test is. So now you got it clear. Now everybody is clear. Any confusions? I've repeated it multiple times. Don't forget Z-man's test. Even if you take this home, I would be very happy. Got the idea? Okay, fine. Right. I've got a yes, sir. Now we move on to the 20th question. See, again, now I won't take this question. Just read my two important things. TB, lumbar. Now give me a diagnosis. Lumbar and TB. Bus, simple, finished. So anyone has anything else? See, this is how simple things are if you practice questions. See, this is a question that is taken from INSET, which was conducted recently, and see so much of drama, and the answer is simple, one line. Psoas abscess. Anyone has any questions on this? Low grade fever, weight loss, low back ache, everything is in the retroperitoneum, right? And this turns out to be tubercular, likely to be psoas abscess. So this is also psoas abscess. Anyone has any doubt on this? Such questions are very common. Okay, whenever you see TB, don't forget psoas. Okay, I'm not saying every time it will be psoas, but yes, 10,000 times out of 10,000, 9,000 times it will be psoas abscess. Okay, chalo. Now I'll move on to the 21st question. A 4-year-old girl was brought to the pediatrics OPD with history of delayed developmental milestones, muscle weakness, intolerance to exercise, lethargy, irritability, recurrent hypoglycemic episodes. Now, always remember, all of these things are related to only one thing. This is a particular thing that is produced by liver, right? So when this hepatomegaly or liver enlargement will happen, this particular thing goes down. And when this thing goes down, the pediatric patient, usually because of this deficiency, develops these kind of problems. They will have intolerance to exercise, they will be lethargic, they will be hypoglycemic, they will be having low gluconeogenesis, right? They will be having low blood glucose levels, they will be having low enzyme levels that are secreted from the liver. So which of the following investigations do you think that is important as far as these conditions are concerned? I'll always tell you, always follow your one particular aspect. Liver is getting enlarged, liver releases this particular thing, and this particular thing is not getting released, so that is why all of these problems are happening. So what exactly is the thing that the liver is not able to generate, or basically it's not getting synthesized, which is causing all of these problems to come? Anyone wants to go for a bluff? Any option? Let's see. Which of the following do you think it's right or wrong? Anyone? A. Karunamai say A. Anjali says 1 or 2. So you guys are right. See, half of the times you are right. Okay, it's carnitine deficiency. Carnitine biosynthesis, when it doesn't happen, that is the reason in children, when they come up with carnitine deficiency, they will lead to hepatic, or it is also seen in hepatic cirrhosis when the liver is not functioning. So whenever you get questions related to liver, and you have got, see, liver is responsible for what? Gluconeogenesis. If gluconeogenesis is not happening, definitely this patient will not be able to produce glucose. And that is why they have got random they have less glucose levels. The enzymes of the liver are much higher. These are all enzymes which are related to the liver, ALT, ASP, ALP, right? They are also increased. Now, also, the second function of the liver is to cause detoxification. Detoxification is not happening. That is why blood ammonia as well as serum creatinine levels are getting raised. So my liver is not functioning. And this is all related to only one thing here, that is my carnitine biosynthesis. And that is why it is not happening. Because it is not happening, these all things are coming up. Simple? Understood? So even if you bluff on these answers, you will get it right. Okay, so simply think. Okay, so carnitine biosynthesis, if you want to read up more about carnitine biosynthesis, go and read up carnitine biosynthesis. Carnitine is very important for you. But this is just to give you an example what exactly happens in such particular conditions. Okay, now, last question. I'll be very fast. Just tell me fatafat, because this has got nothing to discuss. This is just about biochemistry, and if you know it, you know it. These are those questions. An 18-month-old child presented with hypoglycemia, drowsiness, and poor feeding. USG abdomen revealed a child had fatty liver again, and further investigations revealed the presence of octanoic acids in blood. Which of the following enzyme deficiency is the most likely to cause it? Now, what exactly has happened? in this particular patient. So what has gone wrong? Anyone? Which of the enzyme deficiency do you think is not there? So this is something which is very, very straight biochemistry question. See, I'm definitely sure you guys are reading your biochemistries very well, because every time I ask you biochemistry, you are always right? It's medium chain acyl CoA dehydrogenase deficiency. That is why this child is having these many problems. So this is a very straightaway question. I won't go into the details much. Otherwise, I won't be able to cover all of the questions that I have for you. Right. A is the right answer. And most of you have got it right. Okay. Now I go to the 23rd question. Jamaican vomiting sickness is caused due to consumption of unripe ackee fruit. Now, this is something, a fruit. Now, this fruit contains a toxin. Now, this is also something which is a very straightforward question, because you don't need to put any logic behind it. So this is a fruit which has got a poison in it. And this particular poison causes something called as Jamaican vomiting sickness. Can anyone tell me the name of that poison? Anyone? This is a bonus question. You've already see, all of these questions are already ready. It's hypoglycemia, absolutely right? I'm so happy that you guys know such difficult questions. When I was a student, I never used to know all of this. I seriously used to find the other questions more easier, but these questions are straight away not very, enterprising for me, because they are still difficult for me to understand. Okay, but you guys are right. Hypoglycemia is the right answer. Great. And I really love the way that you guys are reading biochemistry, because this is very important subject. 15-20 questions are going to pop up in your main exams. Okay, now I lead on to you for my second last question. A 40-year-old male who has traveled to Jamaica, so we are having some Jamaican things today, developed severe vomiting, convulsions, and hypoglycemia following consumption of an unripe ackee fruit. Now, the national fruit of Jamaica. Again, which of the following enzymes of beta oxidation is most likely to be affected in this condition? Okay. Before I complete, you guys tell me. Again, you guys have told me. So I'm very happy that Janice ma'am is, doing a great job teaching you guys. So acyl CoA dehydrogenase is the right answer. Okay. This Jamaican fruit has been asked a lot. That is why we have put up questions for this, because this has been one of the favorite things that has been asked in your NEAT-PG recently. So that is why these questions have popped up. Right. Okay. Now I'll move on, because this has got no concept behind it. It's just about knowing. Right. Now I move on to my last question for today for you. A 4-year-old was brought to the pediatrics OPD with symptoms of upper respiratory tract infection associated with vomiting, dehydration, difficulty in breathing, decreased muscle tone, and irritability. She was also noticed to have delayed developmental milestone and a stunted growth. Now, an arterial blood gas analysis showed she had metabolic acidosis. This is something that you will read later on, that there is basically, in metabolic acidosis, there is nothing. The bicarbonate levels in our body falls. That is called as metabolic acidosis. Now, organic aciduria was suspected, and analysis for urinary organic acids was done, which revealed presence of high concentration of methylmalonic acid. Now, this is the only line which is present here. Which of the following deficiencies of vitamin is going to cause this likely condition? Okay, can you tell me what is the right answer? Ram Pranav is saying D. Anjali is saying biotin deficiency. Anyone for any other answers? Anyone? So organic aciduria, Anjali is also saying D. Do you want to change your answer, Anjali? Anjali has now thought something. Anyone? Shifa, Karnamay, Farheen, Gopika, Anaga, Satrupa. You can go. You can go ahead and you can say. Karnamay says A. B1. Answer is B12. Okay, answer of this particular thing is B12. Now again, see, always see, muscle tone, decrease muscle tone. Again, whenever there is a muscle, whenever these vitamin B12 deficiency comes, right, always there will be difficulty in two things. One, they will be always lethargic and they will be always having muscle tone problems. Okay. Second, they will be always tingling of extremities. Always notice that. Okay, so that is the reason when they come up with these kind of problems, see this, they have decreased muscle tone, they have irritability, they have got developmental milestones. That means they are not growing properly. All of these points towards a specific vitamin, right? So that is vitamin B12 deficiency. And second clue was organic aciduria was suspected and it revealed high concentration of methyl malonic acid. That was the second part. Okay, so I hope I have rushed in the last two questions. So I hope you guys have understood something out of today's session. Okay, and whatever doubts you have or whatever things you need to understand, you can put it up in the chat box. I will come back to you and I will get your answers sorted, because this is what my word rounds are. I take you for a word discussion because of the fact I want you to participate as my junior consultants. I always call you guys my junior consultants, because I don't want to be a senior consultant just alone. I want you guys to participate. I want you guys to come in. I want you guys to, bring the concept with you. And, this is what a healthy discussion is. In the next word round, what I want is when you join me, I'll make something interesting for you. Okay. What I'll do is I'll try to put up certain scenarios where I want you to be a little more vocal and discuss with me. Okay, so I'll make such scenarios. Maybe I can keep some kind of pictures for you. I can keep some kind of real patients for you as pictures, and I can show you what exactly happens in these patients when I come up for the next word round. Okay, so till then, I'll wait for that chance to teach you guys again and come back again, and I'll leave you with the rest of your teachers so that you can keep gaining all the knowledge. Okay, don't forget to attend all your live sessions that are happening, your dissection sessions that are happening. These will keep you updated and this will keep you going on. Because once you miss, you will going on to miss a lot of things. Okay, so keep on track, keep up with the pace. Right? So that is a good night from my side to all of you. I hope you guys have enjoyed today's session, and I have enjoyed very well talking to you guys and teaching you guys. And keep up with the pace, keep reading, keep scoring more, keep getting your Polaris points, and I want all of you guys to excel in your life. Right? So keep reading and keep excelling. Okay. So I want to end the session. Right. So can we have a end of today's session? I think we have completed our word round. So I wish the students all the very best and a very good night to all of you.
Thank you guys for joining in.
Yeah, thank you.
Have a good day. Bye.